Okay, thank you guys. Well, I want to thank the Seattle Foundation for allowing us to host tonight's interesting case conference. And my name is Steve Ludwig. I'm at University of Maryland and Chief of Spine Surgery at the R. Adams Cowley Shock Trauma Center. And we were asked to talk about our experiences and show some interesting cases with regards to cervical and thoracolumbar trauma. Tonight, I'm hosted by our three fellows. We'll do a quick intro of everybody, as well as three of my fellow partners that participate in the case discussion tonight. Our goal really is to have an interactive discussion amongst our group of surgeons and a case-based analysis of different common to at least us, but interesting cervical and thoracolumbar injuries. And what we'd like to do is we'd like to attempt to talk through some of the pearls and pitfalls of some of the approaches that we use for these cases, and to review and cite some of the pertinent literature with regards to these cases, and really for the audience and the people listening to get some key points and take-home points that they can generalize for other injury patterns. And the goal is not to talk about every single cervical and thoracolumbar trauma subtype of fracture and management, but once again, to talk about the general principles that are pertinent that, once again, you could take home some key learning points. So with that said, I'd like to just introduce some of the key people that are on this webinar. Dr. Gelb, Dr. Coe, and Dr. Cavanaugh, who are three of my partners that are involved in the treatment of trauma at the University of Maryland and Shock Trauma Center, and our three current fellows, Dr. Nina Lara, Dr. Peter Cohn, and Dr. Sohib Hashimi, as well as our research fellow, Dr. Jacob Bruckner. So let's just dive right into it. And I think Dr. Cohn is going to start with the first interesting case. So Pete, if you can sort of take over the flow and start that case, that'd be great.
Will do. I'll kick this off. So this is our first case. This was transferred into our hospital, 74-year-old male who arrived after a mechanical fall, laying on his face, and he had immediate neck pain. When he arrived, he was intact for motor and sensory reflexes, and just had a past medical history of hypertension and diabetes. And note he's a non-smoker. He arrived with a CT scan, and I'll show you some select cuts. So these are the sagittal images of the CT scan, and you can see a type 2 odontoid fracture angulated posteriorly. You can also see an interruption of the anterior ring of C1, and then you can also see the ankylosed subaxial cervical spine here. On these sagittal cuts, I just wanted to show the fused facets as well as the occipital cervical joint. And there were some coronal cuts. They just demonstrated again that it was a type 2 odontoid fracture. And then here are axial cuts demonstrating that anterior ring injury, as well as the posterior ring fractures bilaterally of C1. And just continuing the axial images down. So really brief, I thought I'd throw in some classification slides. So for the C1 injury, you can divide these into 5 types, the type 1 being an anterior ring injury, type 2 being a posterior ring injury, often with 2 fracture lines, type 3 being the Jefferson fracture with the A and B variants, A being with an intact transverse ligament and B being with the ligament injured, type 4 being a lateral mass fracture, and type 5 more of a transverse process fracture. There's also the Dickman classification describing the type of ligamentous injury of the transverse ligament, either intrasubstance or an avulsion injury. For odontoid fractures, there's the classic Anderson and D'Alonzo classification, which first described the type 1 injuries, which are more of an avulsion, type 2 injuries through the base of the neck through the watershed area, and type 3 injuries through the facets, with the important takeaway from their study being the 33% non-union rate of the type 2 injuries treated non-operatively. There's the AO classification as well, and I know this is busy, we'll just summarize real quick and move on. But you can have type 1, 2, or 3 injuries describing different anatomical locations, either between the occipital condyles and C1, between the C1 ring and the C1-2 joint, or the C2 body and the C2-3 joint. And the injuries can be described as A, B, or C types, A types being bony, B types being ligamentous, and C types being unstable translational injuries or rotational injuries. There are also modifiers for our injury type. The most applicable one would be there's a modifier for the increased rate of non-union for the type 2 odontoid fracture. So to summarize, there was a C1 osseous Jefferson fracture and a C2 type 2 odontoid fracture with posterior angulation in our patient. He also had a CTA that showed no vertebral artery injury. So at this point would probably be a good point to open up the discussion and talk about the different treatment options. I've summarized most of them here. I don't know if anyone had any comments or wanted to say what they thought might maybe should be done.
Dan, you want to take over discussion of this one?
Sure, Steve. I'm glad to. So, you know, treating odontoid fractures and being a spine surgeon and having a case conference is like being a general orthopedist and putting up a Colles fracture, right? We all see them, we all treat them, and we all have lots of opinions about them. And maybe there's been, you know, no fracture that's quite so controversial in the neck as the elderly patient with a type 2 odontoid fracture. Pete, if you can go back in the slides, I just want to the injury films. You know, I look at this injury, keep going up. So the couple things, no, go down now. Sorry, 2 more slides. Right there. So, you know, I would not characterize the C1 ring injury here as a Jefferson fracture, right? To me, a Jefferson fracture is a 4-part. There's an anterior ring piece. There's 2 lateral mass pieces, and there's a posterior ring piece. And what you're worried about in that situation is the splay of the lateral masses in the integrity of the transverse ligament. And despite the way the classification works, I don't think this becomes a classic Jefferson fracture. The other thing you can see, if you look at the top left there, and this is true in very many elderly patients, there is almost a spontaneous fusion of the odontoid to C1, right? So I don't think you're going to worry about C1, C2 instability in this situation. To me, what the ring injury tells me is that this is a higher energy injury than it would be otherwise, right? This is not, even though it's a fairly low energy mechanism, there's been enough energy imparted to the spine here that you've broken both C1 and C2. But I'm not really worried too much that there's going to be C1, C2 instability. It's not surprising that the odontoid fractured. I mean, the spine is hugely stiff below and there's a huge moment arm above. So the only place that's available to absorb that energy is right at the base of the odontoid. And so you get this fracture. You know, the older you are, anything, and you can pick the age you want, 45, 50, 60, certainly 50. The older you are, the more likely there is to be a non-union. Displacement, angulation, and comminution have all been factors that people have said were indicative of the chance of undergoing a non-union. I think so, you know, in this situation, either you're probably going to accept a non-union by treating this in a closed way, and hopefully it'll go on to be a stable non-union and a painless non-union, or you're going to elect to fix this surgically. And in our hands, certainly in Maryland, we have been, if the patient is independent, has good cognitive function, is living independently, and has been active, we have really favored surgical treatment, and I think the bulk of the literature favors that for displaced odontoid fractures, even in patients up into their 80s. And if you can get through the surgery well and quickly and without a lot of blood loss, patients do very well with that type of thing. I think that in the past, years and years and years ago, we would use halo vests, and I think that is a treatment mechanism to be condemned. So if you go to your treatment slide, we can kind of walk down the list there. You know, so if I have a patient who is older and has an odontoid fracture that's displaced, traction almost never is necessary because these are not usually neurologically threatening injuries. We will often put patients who we don't think are suitable for surgery into a collar, or patients who refuse surgery and want to have an attempt at non-operative management, even though the chance of that succeeding is fairly small. Minervas, halos, SOMI braces, certainly halos in general, I think have fallen out of favor for this type of injury because of the high rates of complications that occur. So then you're down to a posterior C1, C2 fusion, or an odontoid screw. And certainly at Maryland, we have favored, especially in the elderly where there may be issues of osteoporosis, doing a C1, C2 posterior fusion with Magarel type or Harms type C1 screws. And then the question becomes, how are you going to fix C2? Because at the upper cervical region, of course, everything's all about the vertebral artery and where's the vert and where can you access safely and get a sufficient fixation. So I think the key here is to go back up to the C2 shots you have and look right there. So certainly a pedicle screw at C2 is going to be your strongest fixation. And on that right upper slide, you can see that it looks like on the right side, there's plenty of room to put a pedicle screw in C2, but the vert on the left may be a little, it's kind of a tight squeeze to get a true pedicle screw on that side. And if that's the dominant vert and you're putting it at risk, then, there's always that chance. And back in the day when we did transarticular screws, there was a 4 to 7% chance of vert injury whenever you put a screw in that region. So you have to respect that, and it can lead to catastrophic consequences. So if you can't do a pedicle screw, or if you're not willing to do a pedicle screw, and certainly people use navigation or whatever to get a screw in there, and they're all options. You can do a pars screw. You can do a screw that goes straight up the pars but doesn't cross the pedicle, and that's a good screw. It's usually shorter is the problem. You don't get quite as much fixation with a pars screw as you do with a pedicle screw. And then the last option would be a translaminar screw, to put a screw across through the base of the spinous process and into the opposite side lamina, which usually there's plenty of room for a nice long screw. Can be a little bit tricky to get 2 screws, one proximal, one distal, so that you have fixation on both sides. But I think those are the major options for posterior C2 fixation. And I think in general, you pick the one that you can make work most efficiently in the operating room. Steve, do you have any other thoughts, or Eugene, anyone? I mean, I've spoken long enough.
Yeah, I think, as you pointed out, most of the salient points of these fractures, I think these type 2 fractures, I'm almost agnostic to what's going on at C1, right? We really seem to focus on what's going on with the odontoid. So in this particular case, as you pointed out astutely, right, age plays a role, displacement, angulation. And I think there's another modifier that you pointed out with the stiff segment or an ankylosed spine, right? And I think we tend to be fairly aggressive, right? We see a lot of these octogenarians and osteoporotic patients in recommending surgery because we have really good critical care management teams in managing their comorbidities. So we feel really lucky to be part of an institution that can get these patients through their medical management issues. I think we position these patients supine. We try to reduce them as best we can supine, and then we sandwich them on an OSI table in a Mayfield headrest and flip them, and it almost becomes a sawbones type of anatomic procedure. We tend to take the reduction whatever we get. We don't tend to manipulate their head and neck around to get a perfect reduction. We'd like to get stability of the C1, C2 segment. I think the vertebral artery is the rate limiting step, as you pointed out, and we rarely will do an anterior odontoid screw unless your body habitus allows it, unless you're young and non-osteoporotic, unless you have the correct anatomic sort of fracture for a type 2 odontoid fracture, meaning you don't have a posterior superior to anterior inferior type of oblique fracture that would slide off when an odontoid screw. So I think those patients typically are managed postoperatively in a soft collar. If we get good fixation to a Aspen type collar, if our fixation is sort of marginal, we use local bone graft, spinous process bone graft and allograft bone, the mineralized bone matrix products. I rarely ever take iliac crest bone grafting for these patients, and they probably go on to a stable pseudarthrosis. And we probably see about 100 of these plus per year. And I can't remember the last one we've had to reconstruct for a non-union. I don't know, Eugene, if you have any other comments regarding their management before we move on.
I was going to jump in, Steve, real quick. I think the other thing you have to recognize is that because we do 100 a year or more, we're pretty facile with it, right? I mean, if this case takes more than an hour and a half before you're finished, that's really an unusual for us. And I think one of the tricks to doing it is, we tend to we put the screw under the arch. You can put this on a C1. Some people go through the arch. We go under the arch and it's directly into the lateral mass of C1. And you really have to flex the head forward to open up that interval. And the times that I've struggled the most is when we haven't had the head flexed enough to open up that interval, and then you're really struggling to get between C1 and C2.
Yeah, that's a really good point to bring up, because I think the other struggle factor occurs when the posterior arch is really thick, right? And sometimes you have to sort of burr down a little bit, but be careful because the vertebral artery can be about 14 to 16 millimeters, from along the posterior superior aspect of that arch. So you have to be careful, but you can burr away with a diamond burr to make that working window underneath the posterior arch a little bit larger to get your C1 lateral mass. Dan, any thoughts on taking the C2 nerve root to improve that working window of the C1 lateral mass versus not taking the nerve root? I like to preserve it. Any other thoughts on that?
When I do these cases, I've gotten to the point now where we get basically an odontoid view or true AP on fluoro, and I target the lateral mass just like almost like you're doing a perk, but obviously we're open. And I target the lateral mass under fluoro, and I don't even look at the lateral mass, so I don't even see. I mean, I don't have to dissect out the C2 root. I see no reason to sacrifice it, but when you do, it certainly gives you a huge open space to work in. But I've become more and more minimal about these things. I take a little burr and I push it into the back of the C1 lateral mass, and then I hand drill up under lateral fluoro and put the screws in without ever really even moving the C2 nerve root.
And I think I could speak for our group. I don't think any of us take iliac crest, right? Would you agree with that before we show the post-op images? Yep.
I agree.
Yep. AP, can you show the post-op images so everybody can see what we did? And then we'll move on to the next case.
So as we're discussing C1-2 fusion, these were just the intraop fluoros. And so there's the lateral mass screw in C1 and a par screw C2. And these were the post-ops. And then I think these are actually 6-week post-ops. They just followed up in clinic not too long ago. And they were doing well. And at this point, he was in a collar, and that came off after this visit.
Great. Thanks, Pete. Let's move on to the next case.
Steve, this is Eugene.
Yep.
Can you just one other thing that, as we tease this out and looking at our case series at Shock Trauma, what was critical was the post-operative care and getting them early nutrition. We found that if they actually didn't do well and had dysphagia and didn't do well with eating, that they ended up getting issues and more complications. So that's just one thing to be aggressive about with these patients is, especially the octogenarians, is to make sure their nutritional status is pretty good and they're actually eating well and able to swallow.
Yep. That was one of our, Steve Clark was one of our previous fellows that published that article, I think in Spine, Eugene. And
Yes.
that it just showed that there was greater morbidity and higher mortality in patients that have dysphagia, and they probably would aspirate. There was something to, with their ability to swallow effectively, have some dysphagia, early dyspepsia, and they developed problems, and they had a higher mortality rate. That's a really important point to bring up at least in our experience. Do you want to go move on to the next case? Is Dr. Lara on or Sohib's on?
Yeah, I'm here. I think I'm going to go before Nina.
Great.
Thank you for having us.
Yep.
I'm Sohab, one of the other fellows, and I'll be talking about one of the cases here. This is a very recent case. This is a 42-year-old female that presented after a head-on motor vehicle collision to our institution. Upon arrival, she was alert and oriented, ×3, and she was neurologically intact on physical examination. Her past medical history included diabetes, hypertension, and a history of polysubstance abuse. At our institution, we get PAN scans of the head, chest, abdomen, and extremities. These are select sagittal cuts. On the far left, these are right parasagittal CT scan cuts showing a entirely jumped C4-5 facet with an associated fracture. As you scroll to the median sagittal window here, and this is the medial sagittal window here, and on the far right is the left facet, which is more than 50% subluxed anteriorly. This is an axial CT scan image of the C4-5 space, and you can identify the complete right-sided jumped facet with an associated laminar fracture at that site. Going one cut caudal, we can also identify that entire jump facet on the right leads to significant rotational deformity of this segment.
Okay, so can you stop right there for a second? And maybe Dr. Ko, Eugene, if you can comment. So we have a patient that's neurologically intact, unilateral cervical facet dislocation, isolated injury. How do you manage that? What's the next step here?
I think the next step for me, at least, is as long as they're awake and alert and oriented, and they're communicating, we should probably get, for me at least, I would get an MRI to make sure there's not a traumatic disc herniation. And then, depending on how the ORs are situated and how they're looking up and how we're able to get the patient to the operating room, if we're not able to, then I would think about trying to do a potential closed reduction in an alert and an awake and communicative patient.
Dan, Dan Gelb, any role to somebody awake, alert, cooperative like this patient? So I think you said she was intoxicated or just an intravenous drug abuser? Both. She awake, alert, cooperative? Let's assume she was. Dan, role for just going to the OR or getting her reduced and then MRI? What's the order that you think about?
Well, I think that the data that we have certainly suggests that in an alert and cooperative patient without distracting other injuries, who can report to you accurately what they're feeling and who you can examine, that closed reduction of a facet dislocation with tongue traction is safe, and there's no need for a pre-reduction MRI. I do think that once the reduction has been obtained, an MRI should be obtained before going to the operating room. So you know if there's a traumatic disc herniation that's been migrated behind the body or whatever. But the case reports of patients who underwent neurologic deterioration following tongue traction none of them are in awake and alert patients after, and we reviewed this back in 2012, and all the available data suggested that closed reduction in an awake and alert patient was safe. So I don't feel that that's necessary. And of course, if the patient is awake and alert, nothing is safer than reducing them when they're awake, because they can tell you exactly how they feel and they give you the most accurate neurologic examination. In this case, I would have no trouble, or I'd have no angst about reducing her. And I'd actually prefer to reduce her when she's awake and then go to the operating room.
What do you think of the chances of maintaining the reduction with the associated fractures, not just a pure jump facet, with all the posterior element fractures? Like, can you maintain that reduction even if you get it with the fractures?
Oh, I think if you get the reduction and then you would reduce the traction weight a little bit, maybe by a third, position the patient so that their neck is in relative, at that point, when you do the reduction, you may want to go straight traction or even a slight bit of flexion to try to get the facet to jump over. But once you get them reduced, even with the fracture, if you put them in a little bit of extension, reduce the traction weight, and then you're going to put them in, especially depending on how you're going to treat this, either anterior or posterior, but if you're going to do an ACDF type of operation, you don't have to reposition them. You should be able to maintain that reduction.
Eugene, is this case coded? Are you waking up in the middle of the night and getting this done, neurologically intact? When are you doing it, Eugene?
You're muted, Eugene. Gotta unmute.
Seconds. Can you hear me, guys?
Yeah. Mm-hmm.
In this type of patient who's, depending how the ORs look like, and she's neurologically intact, I don't think there's a rush to go to the operating room. But because the patient is dislocated, I worry about an evolving neurological issue that could happen, particularly about there isn't much more room for the canal, potentially. There could be bleeding from an epidural hematoma that becomes slow, that can have a progressive neurological deficit. So I think I would probably discuss with the fellows what the operating room looks like, potential of, if it looks horrible and they're jacked up, potentially looking into trying to close reduce this patient. And also looking at what the MRIs are. So it all depends on what it is, but I'd be more urgently worried about this patient involving a neurological deficit, that I'd want to, at least, if we can't get to the operating room or get an MRI fairly quickly, at least try to attempt closed reduction.
Yep. So this was my case. I want to move things along a little bit. This is somebody that came in pretty early in the morning, around 5 o'clock in the morning, came in with a unilateral facet dislocation. ORs are available, right? First thing in the morning. I code this case, I get a stat MRI. So if you want to continue on with the presentation, can you show the MRI?
Yeah, so this patient had an emergent MRI performed after a hard cervical orthosis was planed for relative stability. And this does show actually a partial near full tear of the ALL, a significant full tear of the PLL with extrusion of the C4-5 disc into the canal space, and actually a little bit cranial into that fore body. These are just select cuts from that MRI. So briefly talking about the different types of classifications that have been proposed over the years for these injuries. The Allen Ferguson the system was the most descriptive in terms of its mechanism, being compressive flexion, vertical compression, distractive flexion, compressive extension, distractive extension, and lateral flexion, purely descriptive and purely mechanistic. And then that was basically built off of when the cervical spine injury severity score was developed. And this looked at the four regions, the anterior right, left pillar, and also the posterior column. Each of them were then scored based on their bony and ligamentous injury. And then I think in the evolution, the next step was the ESLIC subaxial cervical injury classification system, which then took fracture morphology and the ligamentous complex in addition to the neurologic status of the patient, which was the next step. And they proposed that a score greater than 5 would be operative. Another classification that's more recent than that was the modified AO classification. One of the benefits of this, especially for the type of injury we are discussing, is they have a modifier that's specific for the facet injury, taking in account whether it's unilateral, bilateral, or perch facets also. So that does add. However, there's no score that's been the threshold for operative treatment in this classification, and purely, I think, still based off of research. And so the treatment goals with this type of injury, treatment of a spinal cord injury, if it is present with bilateral facet injuries, that chance is greater than unilateral based on the data. The fracture or dislocation reduction is critical. Surgical stabilization when feasible after advanced imaging of the MRI is complete, and obviously early mobilization, rehabilitation of this patient. So this patient went on to an anteriorly based approach with ACDF of C4-5, and the patient actually had a complete discectomy performed prior to a reduction procedure with the Caspar pins in the operating room.
So let's just talk about, if you go back to that. So Eugene, can you talk a little bit about reduction techniques? So this is somebody that we brought to the operating room just because timing, and that's really a critical point to this, unless somebody is having an evolving neurologic deficit or a change in their neurologic status, of course, those patients are emergently brought to the operating room, right? They are code 1, we get them in. Patients that are reduced because there's some timing issues getting to the OR, neurologically stable, yeah, we're waiting till the next morning, right, to get them done. We're not doing it in the middle of the night. Patients that we can't reduce, of course, or patients that are dislocated, yeah, these are urgent cases. We want to get them reduced. We want to get them in the operating room and stabilized, right? So this is a neurologically intact patient. They have a traumatic disc herniation at C4-5. They have a unilateral facet fracture. They don't have osteoporosis, presumably, and they don't have a subchondral end plate fracture with a relatively high mechanism of injury that we decided to do an anterior-based procedure. Eugene, any discussion in pearls about reducing these patients from the front?
Yeah, that's a good question, Stephen. I think you mentioned something that, in particular, you want to make sure that they don't have any end plate fractures. You know, some of these issues with end plate fractures and some of the techniques that you can help reduce would be using mini laminar spreader to distract and open up that disc space so you can get that, you know, the superior articulating process and the IAP to be reduced. So you need some distractive forces. If they have pretty good bone and there aren't any end plate fractures, then I think what you would particularly do is you can use a Caspar pin where you can distract gently and then do a little bit of a kind of put the head in a little bit of flexion to distract a little bit more to get the IAP and SAP to be reduced in the proper location. And those are certain things that you can do to help that out. they have end plate fractures, I'd be very careful with doing the Caspar pin technique, or if they're osteoporotic, or using a mini laminar spreader. I think the ones that I typically get up very difficult to do would be the C7T1 jump facets. And often with those, it's hard to get the C7T1 done on fluoro. And often what I've had to do is abort the anterior approach, but do a posterior based approach. So I think it all depends on if you don't have any end plate fractures and they're not osteoporotic. I think an ACDF is perfectly reasonable to help reduce that approach.
Yeah, there's a nice descriptive procedure that people will use in that case when you can't obtain a reduction, right? You can do your discectomy for your traumatic disc herniation, but you can't reduce the dislocation. Sometimes unilaterals are hard. Bilaterals, usually there's so much disruption that they're much easier to reduce with distraction, compression, and then extension, distraction, flexion, and then extension. So those are a little bit easier, but the unilaterals can be tough, especially as you remarked on if they're 6'7", really big burly people. They're not paralyzed because we're following their neuromonitoring potentials. So if we put a piece of bone in and we put a little kick plate and attach that to the superior or the more proximal vertebral level. So in this case, it would be attached if you couldn't obtain a reduction like we were able to at C4-5. We would put after we did the discectomy, we would put the bone graft in. We would apply a plate, like almost a kick plate, onto C4, and then go in the back, do a reduction, and allow the kick plate upon the reduction to almost drag the graft back in and get your final reduction and stability in the back. So I think those are some key points that can be helpful pearls. So why don't you go on and show us what we did?
So we did anteriorly based discectomy of that traumatic disc herniation along with a PLL that had gone posterior, as well as reduction with Caspar pins like we talked about, which was obtained, and then did a fusion of that C4-5 level.
Hey, before you move on, I just want to make one quick point, if I may. Go back one slide. Notice how gapped the facets are under distraction there, because when you have these facet injuries, you have really nothing in the back tethering, and it's very easy to put a very large graft in here, and it's tempting because you want to fill that space. But now go forward. I think it's really important to see how well you reduce the facets, not just translationally, but maybe undersizing the graft, maybe making sure you remove traction before you plated. But you really don't want to see those posterior facets gapped, because that puts a lot of stress on your anterior hardware. And I think it's a kind of a nuanced point, but when you're reconstructing these from the front in an isolated fashion without posterior fixation, you got to make sure you get the back reduced in that way. Otherwise, and it's very easy to miss it because you can put any size graft in there that you want.
Yeah, that's an absolutely great point. I tend not to overstuff the joint, and that's a good way for the failure of an anterior-based approach for these type of fractures if you overstuff.
Eugene, when you reduce it, do you usually use traction?
I would typically try a traction-based approach with weights to do that. Just
in the OR, right?
In the operating room, yeah, because I think it's probably easier to get it reduced versus some of the other techniques. And I also worry about the patient's bone quality with trying to manipulate it with mini laminar spreader or with the Caspar pins. I think it's sometimes more difficult to do that.
Yeah, I typically keep these patients in collars postoperatively as well. We try not to brace people after their injuries, after we do their fixation. But these are significant discoligamentous injuries, as Sohi pointed out. So postoperative, I typically leave them in a collar for about 6 weeks. If I do go front back in certain circumstances, if they're osteoporotic, if they have subchondral end plate fractures, if I can't get the reduction right, I typically will, in a young, healthier person, I typically won't keep them in a collar, but in an osteopenic or porotic patient, I will. Last thought, somebody in a different category that is neurologically incomplete or complete, Dan Cavanaugh, any role of steroids in somebody that's young, healthy, no other medical problems, 25-year-old person? Let's start with Dan. Gelb, thoughts on steroids?
I've not been a great fan of steroids. In that patient that you described, probably no harm. They're unlikely to suffer the negative consequences or be hurt by the negative consequences of high dose steroids. So there's the benefit without too much of a downside. But anyone who has multiple injuries, pulmonary issues, elderly, I would certainly avoid.
Eugene, Dan Cavanaugh, any other thoughts on steroid use?
I typically don't do the Bracken dose of steroids for these patients because just of the other complications that can happen.
Yeah, I mean, I'm the same way. I tend to err away from the large, massive doses of steroids, although I do oftentimes give people a little Decadron, like a much smaller dose, without good evidence for that, to be quite frank with you.
Yeah, I think, you know, these are guidelines, right, and recommendations. The reality check, I think if you're older with a lot of medical comorbidities and polytraumatized, in somebody neurologically incomplete or complete, right, we're talking about a different animal, different patient, right? We probably don't do steroids because of the downsides that Dan had brought up. But in somebody that's young and healthy, no other traumatic injuries, right? I tend to, I would probably, I would give steroids to somebody in that patient category. Why don't we move on to the third case? I think Dr. Lara is on.
Hi, yes, I'm here now. Thanks, guys.
Great.
Is somebody gonna load the slides? Thanks.
Great.
All right. And then I can just, can I control these slides here?
Yes, you have control.
You have control, Nina.
What do I push to navigate it because it's not working?
If you click the screen once, that should activate it, and then use the arrows in the bottom left corner.
Okay. All right. So I have a 74-year-old gentleman who was a strained passenger. He was involved in an MVC accident. He was actually stopped at a traffic light and rear-ended by a car going about 70 miles per hour. He was found alert. He had abdominal pain and back pain when he came in. His past medical history is mild dementia. His physical exam, he had bilateral upper extremity neurovascularly intact, no deficits. He had no motor or sensation to his bilateral lower extremities. And then he did have a palpable step off in his distal thoracic spine. He had perianal sensation that was absent to pinprick, decreased rectal tone, and attack bulbar calf reflex. Negative upper motor neuron signs. You can see here he has evidence of a T10, T11 fracture dislocation with 10 fractured posteriorly or translated posteriorly on 11.
Nina, if you want to go back to that slide, that'd be great. Thanks.
Sure.
So Dan Cavanaugh, walk us through timing, need for MRI, decompression. It sounds like we have a T10-11 fracture dislocation, not really a polytraumatized gentleman. complete spinal cord injury, even though he may be in early spinal shock.
Yeah, I mean, I think the quality of the exam, the initial exam, I think is critically important. I mean, I think that, really teasing out whether or not this guy is complete versus incomplete. I think if you look at the number of people that are complete on admission, right, and their exams done within the first, couple days, if they're really truly complete, the chances of them having substantial neurological recovery are very low. Certainly if they have incomplete, right, if they have sacral sparing, any sensation, in my mind, it's a completely different, course for these people. So if I truly believe they are complete, and I believe that the exam is reliable, it's not a patient that's, has a head injury, not a patient that, that is confounded, inebriated or something like that, then I think that the timing of this, I don't classify these as urgent cases. I would certainly wait until the next day if this came in the middle of the night, et cetera. If I believe they're complete,
For an MRI, Dan?
I would not get an MRI if I believe they're complete. If they're incomplete, or I don't feel like I could get an exam on the patient, I would probably get an MRI.
Thoughts about surgical plan, number of levels? What are your thoughts on?
Yeah, so I think, this is an older gentleman. Obviously, with a complete injury, my goal with these is to, basically stabilize their spine so they can get mobile as soon as possible. Allow them to sit up in a wheelchair, allow the trauma team to perform adequate pulmonary toilet so they don't get a pneumonia, et cetera. So obviously stabilizing this in a low morbidity fashion, would be ideal. Now, this is an older gentleman. I think he's 74. Bone quality plays a big role in these kind of fractures. If this is, let's say, a 24-year-old versus a 74-year-old, it really plays a difference about how aggressive I am with the number of levels, the use of cement augmentation, et cetera. So this is an older guy. I would assume he's probably osteopenic, and I would probably err on this, and it's a very unstable injury. So I would probably err on the side of, doing a long construct, at least 2 above, 2 below the injured levels, with the level of injury. And, even considering the use of cement augmentation if I needed to. If this is a younger patient, I think a short construct may be very reasonable.
Yep. Dan, Gelb, any thoughts on somebody that's polytraumatized? So I think this is an isolated injury, right, Nina? No other injury patterns in this patient.
He did have an aortic injury that was initially deemed non-operative. Actually, after his spine surgery, about a week after, he actually did undergo surgical repair of his aortic artery injury or aortic injury because the pseudoaneurysm was getting larger.
Yep. So in somebody that's polytraumatized with life-threatening injuries and other extremity orthopedic injuries, how do you discern on who goes first? When do our other orthopedic colleagues go versus fixing the spine?
Yeah, I mean, I kind of think about, ABCs, right? Go back to that. So obviously, if he has an aortic injury and he's hemodynamically unstable, that has to obviously be addressed first, right? So take care of the life-threatening injuries first. I kind of go back to these. I treat these, kind of the same way you would open femur, right? Disaster control orthopedics. We're trying to minimize morbidity and get this guy up. So I like to do percutaneous fixation on these if I can, because it's faster, lower blood loss, in and out of the OR more quickly. So if I could percutaneously do this and it reduced reasonably well, I would even consider that for this kind of case rather than opening.
Yeah, so in terms of polytraumatized cases, right, we look at the life-threatening injuries first, right? Abdominal, head, chest injuries, those are taken care of first. Long bone fractures are typically stabilized next, right? Femur, if they have an open book pelvis, long bones, tibia, humerus, etc. And then as long as they're stable, right, sort of tag, we come into play, right? Lactate level, serum lactate level, we use as a resuscitative measure, right? In the face of a normal serum lactate level less than 2, or normalizing serum lactate level in the face of a polytrauma, that shows that they're adequately resuscitated, and we can go ahead and do the procedure that Dan was describing. Whether or not we use minimally invasive techniques or open techniques. Dan Gelb, you want to talk about sort of thoughts on reduction, right? Sort of the goals are reduce this, stabilize, to get them up quickly, mobilize, prevent against all the recumbent morbidities, right? So how are we getting this reduced?
Yeah, that can be very difficult because it is such an unstable injury. I mean, this is really, you can see by the degree of displacement that there's really nothing, there's a complete discontinuity through that segment of the spine, and there isn't even comminution of the bone to afford you some help. If you're lucky, when you put them on the table, they will reduce. And certainly if you're doing things percutaneously, that's almost mandatory before you can go on. But in the ankylosed spine, we often see that they actually get worse if you don't position them carefully on the table. Sometimes we'll use a Wilson frame as opposed to the open frame of the OSI table to avoid an extension moment or to make this worse. I think you can use your screws if you put, just like we would do in other places in orthopedics, put screws in above and below, and then attach the rod to, in this case, because the proximal segment is posterior, put the rod in the proximal segment and then actually use reduction screws in the distal segment to kind of bring the spine together would be one way to get this reduced. But I think that's certainly easier to do open than it is percutaneously. Yeah,
I agree. I think, if we're going to do this percutaneously, it's almost a hybrid technique. It's almost impossible to reduce. This was a tough fracture. This is one that I had done. There was a lot of soft tissue destruction. The spine is very unstable. You can put the spine almost anywhere you want. This is acute spinal deformity, but very, very loosey-goosey. It's not like a complex adult spinal degenerative deformity, which is tough to move the spine in space. But if you're going to do this MIS, you would have to do almost a hybrid approach where you're going to open up at the fracture site, take out the dislocated facet joints completely, make it even more unstable, perk your screws above and below and pass the rod and do your reduction, as opposed to opening up, doing an open, more formal open reduction. I tend to take out the joints to make the spine even more unstable, and then I could reduce it in place. I think you have some slides talking about reduction techniques and sort of number of fixation points. You want to share those? We're going to almost finish up here.
All right, so these are your post-operatives, just for completeness. So just, briefly, so surgical outcomes, this was a study that included 20 patients with thoracic or lumbar spine fracture dislocations. And they pretty much deemed that, they identified failure as anything that translated 10% more than prior reduction. And they found that treatment with short segment fixation with pedicle screws has a reported failure rate of 26% in the thoracolumbar region, and even higher in the lumbar spine. So they recommended to go at least 2 up and 2 down below the translation site. And then this paper here was in AO Spine in 2017, and they talked about a reduction technique where you use 4 rods. So you place pedicle screws above and below the translation site, put 4 rods, and then you use 2 vice grips to get your reduction. You essentially create the deformity, or you recreate the injury pattern initially to get your reduction and then placing traction, and then whether you go anterior or posterior with the translated segment. And then you replace on one side unilaterally a long rod to get your fixation, and then turn around and replace the other two rods with your long rod. So this is just a technique that's described in the literature. And then other studies, and they're pretty much all case series that are available in the literature. But this again looked at 16 patients with thoracolumbar fracture dislocations that were treated via posterior approach only, and found that this was posterior alone approach is safe and biomechanically reliable with good outcomes. They didn't have any patients who lost correction or needed revision surgery.
Yep. So a couple questions before we round this this discussion to the end. Most of these cases are neurologically complete. It's very rare that they're incomplete, at least in our experience. If they are incomplete, they typically don't have a lot of canal compromise, and the neurologic devastation is from the dislocation. So the decompression in the neurologically incomplete comes from the reduction. And then there's a re-imaging, and if there's continued canal compromise, perhaps an anterior-based decompression is warranted. Any role, Dan, for you, there's been a couple of questions on the role in the complete patients for neurologic decompression. I'll just go around. Dan, Gelb, any role? Neurologically complete?
I don't think so.
Kavanaugh?
Yeah, if they're neurologically complete, I do not decompress. I think that the risks of decompression, outweigh the benefits. A lot of these have traumatic dural tears. If you unroof a traumatic dural tear, now you're dealing with a unstable spine and a CSF leak, then it increases your likelihood of an infection. It's just the cascade of badness, right?
Yep. Eugene, any role in your mind?
I agree. I don't open up where they're complete. I do get neuromonitoring signals to confirm that they are complete. If I have no SSFTVs or motors, then I'll cancel them out and just do a straightforward stabilization. But I wanted to have documented proof that there have no neuromonitoring signals.
Yep, so there's some weak evidence out there to suggest that increasing cerebral spinal fluid flow in somebody that's complete may prevent against post-traumatic syringomyelia. These are very rare cases, I think, very anecdotal. I agree with what everybody's saying. We typically do not decompress somebody neurologically complete. A lot of the complications that Dan Kavanaugh brought up, right? Infection mitigation, damage control of the muscles, EBL loss with TXA, local washes with betadine and vancomycin powder can really mitigate a lot of the infection risks in these major fracture dislocations. So, with that said, we'd like to thank everybody. We're coming to a close. We'd like to thank the Seattle Foundation for allowing us to participate and showing some of their cases and discussing some of our pearls. If anybody has any questions or concerns and want to reach out to any of us, we're happy to talk offline. Our hope is that, through showing some of these 3 cases, they sort of, you can take away some of the management pearls of some common trauma sort of pearls and issues, and you'll be able to take some of these issues and sort of better generalize them to guide some treatment for some other fractures that you're dealing with. So once again, thank you, everybody. I guess we're going to bring this to a close.
And Steve, thank you and all your associates. You all did a great job, and that's why you are known as the shock trauma unit of the universe. So thank you so much.
Thank you, guys.
Thank you, guys.
Good night.
Good night.
All right.
Thanks for watching. Hit the subscribe button for more medical content.